Okay, so I'm Stephen Bell. I'm an Associate Professor of Audiology at the University of Southampton. So this lecture is on objective measures and their use with cochlear implantation. So the lecture is going to be divided into three main sections. The first is looking at pre-implant, how could we use objective measures? And that's going to include a couple of techniques, electrocochleography in terms of ANSD. How to check the integrity of the implant, so how do we check the impedances of the implant. And then the third section is going to be on estimating behavioural thresholds using objective methods. And these can be stimulated through the implant and recorded back from the implant, or stimulated through the implant and recorded back elsewhere. And I'll explain that later on. There are a number of abbreviations in this talk, so I've just listed them here. So use this slide to refer back to for some of the abbreviations used. So at the start of the lecture, I should probably cover some general issues to consider. So when we think about using objective methods with cochlear implants. So the first one is when and why would we want to use objective methods? So for example, when is an objective method more suitable than a behavioural method? It's always worth bearing in mind the evidence base. So what's the evidence that the technique we're going to use is helpful? And a third thing to bear in mind during the talk as a whole is the issue of neural adaptation or plasticity. So one thing we know happens with cochlear implants is it takes a time for the implant to bed in to the auditory system. So for example, the impedance of the implant changes over time. What that means in practice is the thresholds we would measure through an implant will be different at initial switch on compared to a few weeks later, or even that process carries on. So even over a few months to a few years, there will be changes in function. So the measures that we get at switch on won't necessarily be the same as what we'll get later on. It's also possible to do some measures during the implantation surgery. So again, if they were done during surgery, things might have changed quite a lot by the time we get to switch on. Some general principles for this lecture. So one is that when we're going to record an evoked response through the implant, we're going to change the name of the response to basically put an E in front of it. So we're talking about electrical stimulation through a cochlear implant as opposed to sound stimulation, which is the more, I suppose, conventional way to record evoked responses, or some of the evoked measures with sound. So that could include tympanometry or acoustic reflexes. But for example, with the auditory brainstem response, the ABR, then the acoustic version, when we use a sound stimulus with headphones, would be normal ABR. But when we stimulate through the cochlear implant, it becomes EABR, just meaning that we've got electrical stimulation of the eighth nerve. In a similar way, SRT, stapedius reflex threshold, would become ESRT, and so on for the other types of evoked response. Understanding some of the methods I'm going to talk about, I'm assuming some knowledge of electrocochleography, but I'll also briefly touch on that. And I'm going to assume a knowledge of auditory responses, so things like the auditory brainstem response, acoustic reflexes. I'm assuming a knowledge of that prior to this lecture. Okay, so the first section of this talk is going to be on pre-implantation. So when would we use objective assessments pre-implantation? They tend to be used for people who can't cooperate with behavioural testing. So young infants would be the classic group. It could also be people with maybe behavioural delay or learning difficulties, possibly people with older people with cognitive impairment. So when people couldn't carry out standard behavioural testing, then we would try objective testing. So yeah, the younger children in particular can't do a lot of behavioural testings, especially babies, so that they're probably the main group where we would rely more on objective tests. Sometimes we would use objective tests for non-organic hearing loss, so people where for whatever reason we don't trust the thresholds that we get on behavioural testing. So that might be a reason why we would try objective testing, but that's relatively rare compared to the largest group, which is infants. In the UK and in a lot of countries now, most children, when they came for a cochlear implant, they'd have already been through hearing screening. So in the UK, we have the National Hearing Screening Programme, the NHSP. So children coming through to an implant centre would have had otoacoustic emissions and/or auditory brainstem responses carried out as part of a screening programme. If they'd failed the screen, they would have then had threshold ABR carried out by 6 weeks. And they should have had a trial of hearing aids. So the current recommendation in the UK is we would have a trial of a few months of hearing aids to see if there's any benefit before the children get referred through for cochlear implantation. Well, in some cases they may be referred through whilst having the hearing aid trial. But a key point, I suppose, is that some of the objective tests will have already been carried out by the time the children come through to the implant centre. So things like threshold ABR may well have been done already. So some of the possible methods we could use for assessing pre-implant include threshold brainstem responses, ABR. It could be auditory steady state responses. So in the United States and Canada, for example, it's more likely that steady state response testing would have been carried out. Both steady states and brainstem responses give us threshold information. The auditory late response can be used. It's not widely used with children, although the evidence for using late responses to evaluate hearing aids is increasing. In Australia, auditory late responses are being widely used with evaluating hearing aids currently. Cochlear microphonics, otoacoustic emissions, tympanometry and acoustic reflexes are also measures that we could use to assess auditory function. So focusing firstly on the auditory brainstem response, the ABR, we would use this, if it hadn't been carried out beforehand, we'd be using it to assess thresholds objectively, to assess candidacy. So again, I'm focusing here a bit on the UK side. So we'd have standard protocols. There's a link here to the British Society of Audiology resources on evoked responses. So that's got a lot of information about how we would carry out threshold ABR. And the candidacy currently is thresholds worse than 90 dB HL, worse than or equal to 90 dB HL at 2 and 4 kilohertz. So that's what we'd focus on testing in terms of implantation at 2 and 4 kilohertz to see if that criterion is met. In most commonly with profound hearing loss, we won't get anything on auditory brainstem responses when we get up to the limit of recording. So somewhere around 105 dB NHL is the limit for brainstem testing. Steady state responses can go a bit louder than brainstem responses, although an issue to be aware of is there may be artifacts at very high levels with steady state responses. So there's a possible issue of vestibular artifact when we get to very, very high stimulus levels. So maybe just something to be aware of. We'd expect if we test otoacoustic emissions, if candidates are suitable for implants, they generally won't have otoacoustic emissions. The exception for this is a condition, neuropathy, auditory neuropathy spectrum disorder, ANSD. So in this case, outer hair cell function is normal, but either the inner hair cell or the auditory nerve has got some dysfunction. So the brainstem response will be abnormal, even though there are otoacoustic emissions. Again, the BSA has got some good guidance on how to manage cases of neuropathy. There are issues because we can't predict behavioural thresholds very well with ABR. So in terms of setting up a hearing aid or thinking about implantation, then we have to be a bit wary as to whether the thresholds we would get with ABR are a true predictor of threshold. So it's around 10% of sensorineural hearing loss is thought to be associated with ANSD. So the other test we would use with another objective test we would use with possible ANSD cases. So if we suspect ANSD, we would try electrocochleography. And in case of ANSD, we see a cochlear microphonic. So this is the part of the response that inverts with the stimulus polarity. So if we, for example, have clicks of positive and negative polarity, so rarefaction and condensation, we'd see an inversion of the cochlear microphonic response. However, we wouldn't get the summating potential from the cochlear microphonic in cases of ANSD. And then the ABR we would expect to be either absent or not necessarily predict behavioural thresholds. So in the cases of ANSD, many children have still been implanted, and the evidence that it seems to be that with ANSD, children still get quite good benefit from implants. So there's a study here quoted, Dean et al. 2013. It's an example where they're showing good outcomes for children that have suspected ANSD. So as we said, the electrocochleography response, we had the cochlear microphonic but not the rest of the response. They would have had outer hair cell function with OAEs, but they wouldn't have had ABR responses. But these children do well when they've been implanted. The thinking is you're basically bypassing the damaged component where the ANSD is causing this dyssynchrony. So the spiral ganglion cells are being stimulated from the implant array, and that's bypassing the area of where there's a problem. There may be an issue to do with where the problem is. So I'm saying in many cases that benefit is shown. It depends probably where the source of the problem is. So if there was a problem with the eighth nerve itself, so a true neuropathy where the nerve is maybe thin, or maybe the nerve's incompletely myelinated, in those cases then implants may not be so beneficial. But in many cases children do well. So it might be MRI scans can be used to try and assess the function of the eighth nerve, but the reliability of that is not brilliant. So it may be not completely known if there are problems with the nerve or not. So a little bit more information about the electrocochleogram. So I've talked about this a little bit already. So on the left here, we've got some electrocochleography responses. So there's a component, maybe in the middle trace we can see the cochlear microphonic component. So depending on the stimulus used, we'll see something that actually reflects the stimulus that's put in. So in this case, we've probably got a tonal stimulus, a tone pip, and we see the actual frequency of the stimulus being represented at the start of the response. And then we have a summating potential, so an increased slope. So the potential builds up and it reaches a threshold level where we then get firing of the spiral ganglion cells, and so we get action potential. And so we see a slope on the uprising of the potential, of the summating potential, and then the action potential. Depends on where the electrode positions are, and the settings of the equipment as to which components of this we see. So we might place the reference electrode for the cochlear microphonic on the mastoid, so behind the ear, in which case we get quite a crude measurement of the cochlear microphonic. There are tiptrode electrodes that actually sit in the ear canal that may give us a better quality signal, and the extreme If we want to get the best quality we can, we would need to use an electrode that actually goes through the eardrum, so we can place the electrode near the cochlea in the middle ear cavity. However, that's not very comfortable. It needs a surgeon to do it. It needs anaesthetic of the eardrum, so it's not something that's commonly done. So for kind of routine clinical work, it's probably most common in implant centres, I think, to put the electrode onto the mastoid, in which case we only see quite a crude measurement of the electrococleogram, which looks something like the wave 1 of the ABR. So we can separate out the cochlear microphonic from the summating potential and the action potential, because there's this inversion with the stimulus. On the right of this slide, we've got an example of a subject with ANSD. What we see a response. So the top waveform is for a rarer fraction click at 95 NHL, so a loud click. And then when we invert this to a condensation, we see a lot of the responses inverted. So the second response is the inversion of the top response. But what we're not seeing is the classic summating potential and action potential. So there's nothing in this response that isn't inverting when the stimulus inverts. The summating potential and the action potential are a rectified response. So they still go in the same direction even if the stimulus inverts. So this is a case of what we might see with ANSD, so a large cochlear microphonic, but no summating potential or action potential. The other methods we can use pre-implant, so tympanometry, looking for middle ear or conductive issues. So this can help us to obviously inform, depending on whether we've done bone conduction ABR or not. We could also we could have done the brainstem response with both air conduction and bone conduction. So that might tell us if there's a conductive element, and then hopefully the tympanometry will corroborate the kind of results that we're getting. And for implantation, a big consideration for children who've got conductive elements is, does that need management before implant surgery is carried out? So it might be that some treatment for the middle ear issues is done first, for example, to clear up any infections, and then once that's cleared up, then implantation surgery might be the next step. We can also use acoustic reflexes. So with a severe profound hearing loss, we'd expect this to be abolished, and we can use this to cross-check what we get with our audiometry. So when I say, it could be pure tone audiometry, but it could also be ABR results. So we can cross-check our level of acoustic reflexes with the kind of audiogram we get. So generally for a profound loss, we wouldn't expect to get any acoustic reflexes. This might be nice in case of suspected non-organic hearing loss, because if someone's got acoustic reflexes but they're giving a severe profound loss on an audiogram, there's something odd going on. So acoustic reflexes might be a nice cross-check in cases of suspected non-organic hearing loss. So that was a brief run through of the kind of testing we can do prior to implantation. Then once the decision has been made to go ahead with implantation, the next level of which we use objective testing routinely is looking at the quality of the implant contact, so the impedance of the electrode array. This can be done during surgery, and it's commonly done many times after surgery. So this is available on all types of implants, and certainly in the UK it's used routinely at tuning appointments to see if there's change from the previous appointment, to see if any electrodes in particular have got problems on them. So what the method is doing is measuring the impedance of each electrode in the array, the cochlear array. So depending on the type of cochlear implant we have, We might have 12 electrodes or 22 electrodes, and it measures the impedance of each one relative to another one, or so you can have different settings. It either measures from one electrode to some reference point, or you can use the all electrodes as a reference. So a common ground reference means you're using impedance relative to all of the other electrodes. There's some more information about how these things are measured in the reference here, French 1999. And we're looking to see if there's a good contact, essentially, slightly crude, a crude use of the term, I think. But there's a good contact between the implant array and the surrounding tissue. So if we have a very high impedance, an impedance would mean that there's not good flow of electrical current, so there's not a good connection between an individual electrode and the tissue around it. So it might be that there's an air bubble, possibly some inflammatory process. Another thing that we might see is the opposite, which is a short circuit. So if one electrode in the array has actually touched another electrode, then we'd get a very low impedance. So that would be a fault in the electrode array, and it might be that we need to turn off certain electrodes because of that. So both a very high impedance or a very low impedance can indicate a problem. And I've got a couple of examples. This is a screenshot of the impedance test from a Medel device. So in this case we've got 12 electrodes, and we've got a fairly constant impedance. So we've got an impedance here of around 6 to 7 kiloohms across the different electrodes. And this would be an example of good results, so they're quite similar. There's no electrodes here that are particularly high or very low. The Medel system also lets you explore the current spread in a matrix, so between each of the electrodes. But for now, I'm just focusing on the overall impedance test result that we get. And the software here is giving you some guidance, so it's giving some ticks to indicate that it thinks that the impedances are good. This is an example from a Cochlear, I think a CAI device. So we've got 22 electrodes. In this case, there are a couple of problems being flagged up. So the panel here, kind of in the middle, is showing the impedances across the different electrodes. So there's a very high impedance being shown on electrode 12, and the software's flagged this up, so the software's automatically identified that that's a problematic electrode. So in the same kind of ballpark of values that we saw for Medel for the good electrodes, so somewhere around the sort of 6 to 8-ish kiloohms, but then we've got one very high value, and then on electrode 3 and 4, we've got very low values. So this is probably an example of a short circuit. So electrodes 3 and 4 are probably touching each other in this case. Certainly when there's a short circuit suspected, it's a good idea to turn off those electrodes. If it was just one very high impedance, we might want to turn that one off. If lots of them were high, it may become a bit problematic. And depending on whether the subject's at an age where they can give you feedback about how things sound, you may or may not want to turn them off, depending on the feedback of the subject. And then the Cochlear system, the display here also gives a picture of the electrode array, and it shows with red here the implants, electrodes that are problematic. Okay, so that was a very brief whiz through, but as I say, we use the impedance test routinely, and we might see over time, so for example, between the switch on of the implant and subsequent appointments over a few months, we may see changes in the electrode impedances. Quite often they come down a little bit over time as the electrode is used. And then if we see a lot of changes in impedance, that can be a warning sign for certain electrodes. In the worst case, that could be that there's a serious problem with the implant array. So when we see a lot of change in the impedance over time, that's not a good sign generally. So then I'm going to come on to the last section of this presentation, which is to do with how do we estimate thresholds. So both the threshold level and the comfort level, the C level, and how might we do this with objective methods. So if we want to program a cochlear implant, set up a cochlear implant for a young patient, maybe we can't get good behavioural data, how would we use objective methods to do this? The first method I'm going to talk about is doing this all via the implant. So we stimulate through the implant and we also record back from the implant to the response that we get. So when recording back through the implant, this is called neural response telemetry, NRT, although depending on which manufacturer, which implant type you're using, it's also referred to in some cases as the electrical compound action potential. So it's called both things. So we're stimulating electrically through the implant, and we're getting a response from the eighth nerve, and we're recording that response back. So the term for when we're stimulating and recording back is telemetry. So telemetry means two-way communication. So it's the eighth nerve, as I say, being stimulated. We might use something like 80 hertz stimulation rate, 80 pulses a second. So the pulse level is altered until we're getting action potentials being generated in the eighth nerve, and then that activity is then recorded back and sent through the implant back to the recording computer. When we carry this out, we would select one electrode in the implant array. We would stimulate on a single electrode at a time. And then over a clinical session, we might do this across a few electrodes. Depending on the number of electrodes in the system, it can take a while to make these recordings, so you may not be able to measure threshold on all the electrodes in a single session. So you might choose maybe 5 or 6 electrodes, and you're going to measure threshold on that sample, and then you might extrapolate to set up a map for the implant. So what we're recording is the electrical response of the eighth nerve, essentially. So on the bottom left here, we've got a response. So we've got a negative dip followed by a sort of positive peak, and the timing this is a fast response. So we're looking at 340 millionths of a second, so 340 microseconds. So the whole thing's over by about a thousandth of a second. So we have an M1, so a negative trough, and then a P1, which is the positive peak. And this is occurring within about a millisecond of the stimulation going in. So the stimulation level would be increased until we got a response, or vice versa. We could start off at a louder level and reduce. One thing to be aware of, though, is the stimulation can get loud, particularly if you don't set an automatic stopping threshold. So if a map hasn't been set up for the subject, you may not know kind of what the C level is. So there's a risk that you could stimulate too high using electrocochleography, NRT methods. So on the right here, we've got a kind of example of the growth of the response. So this is showing, as we're going up, what's happening is the stimulus level is increasing. So we're getting a bigger difference between the peak and the trough. And at some point, as the level goes down, it will disappear. So we'll get to a point where there's no response. So we can take threshold as the point at which we first get a response. And most of the systems can automatically identify when a response is present. So they can statistically indicate when they think a response is there, although it may be worth also visually inspecting it to see if the response looks what you'd expect or not. When we carry out this sort of NRT measurement, the stimulation rate is going to be lower than the cochlear implant would use when it's in its normal running mode. So there's an issue that the loudness you might hear for the low stimulation rate of the 80 or so a second for the NRT measurements, this would be quiet relative to if we went up to 1,000 a second, or depends on the implant type that we're using. So it's worth being aware that the threshold we measure at the low rate used for this type of recording may need to be corrected in order to predict the threshold for a higher stimulation rate. An issue with this kind of measurement is electrical artifact. So we're stimulating the eighth nerve with electrical pulses, and then we're trying to record back the response to the nerve. However, when we're recording back the response, we'll see potentially the artifact of the stimulation pulse. So in the early days of NRT, this was a big problem. Fortunately, this has mostly been sorted out with how the system works. So there's a clever trick that the software uses, which is if we stimulate the hearing nerve with a pulse, then as soon as the nerve's fired, it will be in a refractory period, and then it won't be able to refire immediately afterwards. So by sending a second pulse quite quickly after the first one, we get the response without any. We see the artifact of the stimulation, but on the second pulse we wouldn't get the neural response. So we can see what the artifact looks like from the second pulse, and we can subtract that from our first recording, which is where we get the artifact and the response. So what's actually done in the system is it uses two pulses close to each other in order to eliminate this artifact issue. It's possibly getting a bit technical already, but it's just something that's been sorted out and is done in the system, but it gets around a kind of technical problem of getting artifacts with these recordings. So we can make these kind of electrical compound action potential or NRT measurements where we're stimulating with the implant and then measuring back through the implant. But the question is, does this actually predict the threshold of the subject? So the evidence seems to be that the kind of level we get with these measurements correlates generally with threshold and comfort levels, and it tends to lie somewhere in the middle of the dynamic range. So the threshold we get with an ECAP or NRT measurement would be between the T and C level of a subject typically. So there's a couple of papers here, Alvarez 2010, Chen 2002, where they've compared T and C levels and ECAP thresholds in a range of subjects. There is a bit of a caveat to that though. So these papers have shown there's a correlation between threshold and the T and C levels, but that's correlation across a group. So there could be individuals where although there's correlation across several people, in individuals it may not predict that well. So we have to be wary of how good a predictor these are for individual subjects. Obviously when someone comes for a cochlear implant, they're an individual, they're not a group of people. So the fact it correlates on average across a group doesn't necessarily help the individual case. But as a guide to shape a map, to give you an idea of if certain electrodes are higher in threshold than others, so we can roughly set up a map, then it can be a helpful starting point. So as long as we're aware of the issues maybe with it not being a brilliant individual predictor, then we can use it as a guide. And also if we set the C levels of the implant at the NRT thresholds, the ECAP thresholds, then that will be a conservative map, so that most likely we'll be setting the sea levels a bit below what the comfort levels of the subject really would be. So as a starting point in a difficult to map subjects, that might be a reasonable starting point. So we can measure a few ECAP or NRT thresholds, extrapolate between the electrodes to set up a map, and then set our sea levels at the thresholds with the T levels somewhere below. Then that's pretty reasonable starting point. So the other way we might be able to measure thresholds is rather than stimulating through the implant and then recording back from the implant, we can stimulate the implant but then record a threshold somewhere else. So we're stimulating the implant, measuring in a different point. One approach that's been used quite widely is the electrical stapedius reflex threshold. So I'm assuming some knowledge of the acoustic reflex here, so the stapedial reflex. So we're using a tympanometer machine to measure the acoustic reflex when the stapedius muscle contracts to loud sounds. But rather than using acoustic sound, we'd be stimulating through the implant. So we'd expect at high levels of stimulation, we may get a stapedius reflex in the same way that we do for loud sounds. So if we play a loud sound to the ear, the stapedius reflex occurs and we see an acoustic reflex. So you'd set up a tympanometer as you normally would for to measure acoustic reflexes. And this can even be done during surgery. Although in surgery, if the ear is open, it may be possible to actually see the stapedius muscle, to actually visually see when it responds to a loud sound. But for clinical use, more commonly, we're talking about in clinic with a tympanometer. And it's best to have two people carrying this out, because one person would stimulate the implant, so they'd be controlling the software of the implant, and the other person would be controlling the tympanometer machine to see when a reflex occurs. Particularly in children, this gets tricky. You might even need a third person who's going to distract the child, play with the child while this is going on. So just managing the software, looking at the reflex, and in some cases managing the patient can be a bit of a challenge. And we'd see a reflex, so much like we would see an acoustic reflex, so that just on the figure here, we're seeing what we normally see with an acoustic reflex. So we'd have some. So on this example, it's taken from an acoustic reflex with a HL stimulation, but for the electrical reflex, we'd be stimulating with a current unit. So we might have 100 microamp current level. So we'd be increasing level by increasing the number of current units, and at some point we'd see the kind of characteristic dip of the stapedius reflex. So up at the high levels, say 86, 84, we're seeing a acoustic reflex. Down here at 78 or so, then there's no reflex. And we're looking at a change somewhere around 0.03 milliliters of compliance would be a typical threshold for where we can confidently say there's a response. Also, we can go up and down in level to repeat, so we can see if the response is repeatable. So we might go up till we get a reflex, go up a bit more to see if it gets bigger, which it should do, and then come back down and see if we can repeat to be sure the level we definitely get a response, and the level where we don't get a response. So where we can do this, there's fairly good evidence that the electrical stapedius reflex threshold corresponds pretty well to the sea level of the patient. So there have been a few studies by Medell, or around Medell devices. So for example, Hodges in 97, that show that the electrical stapedial reflex fairly well predicts sea levels. I have said on this slide there's a practical issue, which is particularly if we're looking at children, will the child actually stay still for long enough for us to be able to measure the electrical stability reflex. So practically that tends to be the biggest issue, is can you do it? Because obviously when the child's got older and they can give you feedback, they might just sit still anyway, and you maybe get them to tell you when it's too loud. So the challenge is, if they're small so they can't give you feedback, would you actually be able to get them to sit still and do the testing? It can be done, but it just requires some clinical skill to do. There are other reflexes that we could measure. So I haven't talked here about things like the electrical auditory brainstem response, where we might stimulate electrically and measure something like a brainstem response. You can get electrical cortical responses as well, electrical steady state responses. But the one that's probably been most, I think, validated for use with implants is the electrical stability reflex threshold. So you can always read up about other types of electrical evoked response and how they link with how they might predict threshold, so T and C levels for implants. So just in summary, we've got a large number of objective methods we could use. We could use them pre-implant, possibly during surgery, and then post-implant. Pre-implant, we tend to use objective measures to confirm hearing thresholds, and also to test for auditory neuropathy, so to identify mainly children where we suspect there's neuropathy, in which case certainly management with hearing aids might be different, and we might take a bit longer before deciding whether to go ahead with implantation. During and after implant surgery, we can measure the integrity of the electrode, so the impedance measurements are used to look at whether the electrode's got a good impedance. And we can use the NRT type measures, there's neural response methods, to try and measure threshold, so try and predict T and C levels. So the NRT type approach is used to measure T and C levels. The impedance measurement to check the electrode array is very widely used. You're probably going to use those in all implants with implant appointments. So yeah, they're done a lot. And NRT is fairly widely used with trying to objectively predict threshold. I should say that behavioural measures are the gold standard. So if the subject can tell you what the sound's like, that's better than relying on objective methods. The problem is when they can't be done. So if we can't get reliable estimates of T and C levels, then what could we do to try and set the map of the implant? And that's when we would rely more on the objective methods. So objective test methods are out there, but it's important to understand the limitations, to understand sort of the evidence for what they can and can't tell you about the hearing of the subject. So I think with any objective methods, it's important to sort of understand its limitations, so before you're going to use it clinically. And okay, it's got some references here listed at the end, so I hope that's given a kind of overview of how objective methods can be used with cochlear implants.